All right, welcome everyone. We're so glad to have you joining us today. My name is Jillian Tallman and I'll be moderating the webinar today. I work on the communications team here supporting PainHQ. PainHQ is an initiative out of McMaster University and we aim to provide accessible evidence-based information on neuropathic pain. So we're really excited to have Dr. Dorfman with us today. He is the founder and CEO of GeneYouIn Inc, a genetic testing company that has developed a proprietary genome analytics platform called PillCheck. He is a molecular geneticist by training and is passionate about pharmacogenetics of chronic pain and genetics of rare diseases. Prior to founding GeneYouIn Inc in 2012, he worked at Cystic Hospital and developed the personalized medicine strategy at the Mount Sinai Hospital. He has published more than 30 manuscripts on genetics of cystic fibrosis, disease-modifying genes, and pain genetics. He has expertise in clinical study design, statistical analysis, pharmacogenetics, genomic annotation, and healthcare strategy. Today, he will be explaining how pharmacogenetic testing can help patients and their healthcare providers identify which medications are more likely to work for them and in which doses. So with that, I will turn it over to you.
Thank you very much, Jillian, for introductions and the opportunity to speak here today. It's really interesting forum, and I would like to explain today a little bit about personalized medicine and pharmacogenetics and how it can be applied through pain management. So let me try to advance the slides. Unfortunately, yes, so it works. So today we'll be talking about pharmacogenetics, which is a science of drug response. And I will be presenting today several new concepts that you perhaps didn't hear before. For example, what is your drug metabolizer status? And I will explain what it means. But essentially, it's a type of inherited phenotype that relates to you and your response to medications, including painkillers. We'll be speaking today about a variety of modalities for pain management, including opioid treatment, and also we'll emphasize how this knowledge can be applied to help physicians and patients to find which medications might be working better for them and enable to control the pain. So we know that pain is very, very pervasive, and it's really an important issue because not only people suffering, but they also die because of inappropriate use of opioids. Some of these deaths are definitely accidental. Pain is also posing huge risk of addiction to opioids. But we know that also very substantial proportion of people are resistant to treatment and suffering chronic pain. So chronic pain is a very diverse term that covers a variety of different conditions, and these are different pain modalities that many times require distinct treatment approaches. For example, inflammatory pain is very different from neuropathic pain that is caused by neuronal injury. Phantom limb pain is just one example of this type of conditions, but anybody who went through surgery and developed chronic pain after the surgery probably suffering from pain because of neural injury that was accidental during surgery or sometimes is inevitable part of the procedure. There are also idiopathic forms of pain, which means that we still do not understand what the cause of this condition is. And chronic regional pain syndrome, fibromyalgia are just a couple of examples of these conditions. Some people are really unfortunate to have a congenital forms of pain. For example, they're born with a tremendous predisposition to chronic pain that is very difficult to treat. Some of these conditions are quite hard, for example, paroxysmal pain disorder and related conditions, but also milder conditions like small fiber neuropathy are developing later with age, and many times we fail to realize that these are actually genetic conditions that we inherited and predisposing us, but become more evident if people are suffering injury or chronic illness. To address these treatments, there are a variety of treatment modalities that are available, and physicians and patients are trying a whole slew of solutions, starting from antidepressants, non-steroid anti-inflammatory medications, even antiepileptic medications such as carbamazepine and pregabalin, helping specific types of pain but not effective for other patients. Cognitive therapy is a really important aspect to develop coping mechanisms with chronic pain. Also, nerve blocks are being recently used more in treating regional pain syndromes, where we can isolate the damaged nerve and at least temporarily block pain signals coming to the brain and provide really temporary pain relief. But many times, this is a very effective treatment and quite necessary in order to reduce breakthrough pains and help people to cope through these terrible episodes. Cannabis is getting more acceptance as a legitimate pain management option, and it's true that it's perhaps the best option for a very small subset of patients, and we need to be very careful to realize who can really benefit from this treatment. Unfortunately, as mentioned earlier, opioids are very broadly used, but they're really not designed for treating chronic pain. And I'll explain what the downsides of using opioids for chronic pain management. So most of people are here perhaps on this webinar know that they tried everything that there is and they still have the pain. Unfortunately, my bad news is that there is no cure for chronic pain. And there are a variety of reasons for it, because it's a condition that virtually impossible to treat. We just need to be able to develop strategies to control chronic pain and let it subside that can take several years to recover. And one of the reasons that, particularly for neuropathic pains, nerve repair and growth takes a very long time. And even after minor injury, sometimes it takes months, if not years, to restore proper innervation to damaged region and reduce pain. The good news is that people actually can learn how to cope with pain. And as I mentioned, cognitive therapy is playing a really crucial role to enable people to remain functional, reduce use of opioid medications, and perform activities that will further reduce their suffering. And McMaster is actually really great in developing this multimodal strategy to help patients to develop their own strategies to cope with pain and become functional members of society. We also know that pharmacogenetics plays a role, and that's my webinar today, how we can apply this knowledge to improve treatment. So pain is actually a heritable trait, and many people don't realize that it is highly heritable. What it means that if two siblings, for example, one of them had a pain-like conditions like inflammatory bowel syndrome or rheumatoid arthritis, the other sibling that inherited the same variations that are predisposing to these conditions is also at very high risk of disease. But not all pains are heritable, and it depends on type of condition. For example, neck pain typically caused by injury or just age. It's not a heritable trait, it's something that we acquired. Also, trauma plays a huge role in disease onset, and extent of the trauma, it also determines how severe the pain syndrome will be. But nevertheless, genetics plays a huge role. And here's just one of the examples. This is a gene that's called sodium channel 9A. And it's a very important channel that functions in nerve conduction. And different variations in this gene actually can cause a variety of conditions, starting from congenital insensitivity to pain, where people have two deleterious mutations that typically reduce production of this protein They don't have this functional channel. The nerve cannot conduct nerve stimulus. So these people, you might be seeing them in circus performance where they can punch needles through their body, not feeling any pain, getting burned. It actually occurs for these people because they are very prone to injuries. Pain has a protective effect. We have to be cautious in order to reduce the risk of injury. So many of these people unfortunately die because of accidents where they underestimate the amount of damage that they can cause to their own body by performing different stunts. However, other people that have gain-of-function mutations in this gene that are indicated here in the blue dots develop extreme pain disorders, for example, paroxysmal pain disorder or erythromelalgia. So these are phenotypically two different conditions, but they caused by different mutations in the same gene. And what it causes, actually, the sodium channel becomes more active. It conducts much more nerve signals from pain-sensing nerve to brain, and that's what causes these congenital pain syndromes. So these type of conditions are extremely rare because they're congenital diseases, inherited, and typically the clinical manifestations starting very early on in the childhood because it's an inherited condition. But most of other forms of pain, they're what we call multigenic. They're caused by a variety of mutations in different genes that are predisposing us to different conditions. And the causes could be different. For example, one person has a more predisposition to increase inflammatory response, and therefore they have higher predisposition to develop rheumatoid arthritis and rheumatoid pains, while other people have enhanced nerve conductivity and might have a higher predisposition to neuropathic pain. So that's a focus of my study, my personal interest, to identify how different variations in the genome can cause increase or decrease susceptibility to chronic and acute pain. So we need to also distinguish between other forms of genetic variations that can impact on pain conditions. For example, we know that people that are more predisposed to epilepsy or depression also have a higher propensity to develop stronger pain. In some women, hormonal response genes are also predisposing women to menopausal pain, but inadvertently, the same variations can increase susceptibility to a variety of pain conditions. As I mentioned, our immune response system plays a really crucial role in development of inflammatory pain conditions, and actually very important research coming from Michael Salter's lab shows not only the role of this gene, but also differences between genders, how our immune response impacts on the risk of pain and how we respond to different treatments. It's actually driven by our immune system. Our personality traits also affect the ability to cope with pain, and catastrophizing is a trait of some people, and this increases propensity of people developing more severe pain and being able to cope less with drugs. So actually today's presentations will not be talking about these type of genetic variations because they're very, very complex, and it will take many hours to cover this topic. Today I'll be focusing only on a very small subset that you can see on the right, the genes that are affecting drug metabolism and also drug response. So that will be the topic for the rest of our presentation. To address this type of different pains, we actually have to use different genetic technologies. For example, to understand full complexity of pain susceptibility, we have to apply really advanced genome sequencing technique in order to cover hundreds of different genes. For understanding drug response, we can actually apply very focused testing. It's called pharmacogenetic testing that analyzes only small subset of genes that are responsible for drug metabolism, transport, and response. So what is pharmacogenetics? It's actually the study of differences genetic variations on drug metabolism and how we respond to these medications, and what would be our own risk of adverse reactions to drugs. And sometimes we don't think about coffee like a drug, but it actually has a compound that is called caffeine. And you can think about yourself, can you actually drink coffee and go to sleep? Very well. I know that I'm very poor caffeine metabolizer. I have to stop drinking coffee at 1 p.m. If I drink at least one more cup in the afternoon, I will not be able to sleep at night. At the same time, my wife can drink espresso and go to sleep. We have absolutely no problems with it. And the reason that she is a fast metabolizer for caffeine. Similarly, the same actually enzyme is responsible for metabolism of nicotine. And our ability to quit smoking is actually related to ability to metabolize nicotine. For example, people that cannot tolerate coffee, they also cannot tolerate nicotine patches. They get agitated, they can get fairly ill. But people that can drink coffee and sleep, the nicotine patches are not really effective for that because they clear both caffeine and nicotine very, very quickly, so it doesn't have a chance to help them. So what we're talking about is that different chemicals, including drugs, have to be absorbed in our body, metabolized in the liver, because liver is a major drug metabolic organ, and these medications have to be secreted at specific rates. And these rates are really important because that determines what drug dose you should be taking. Should you be taking these medications once a day, twice a day, so 3 times a day? And we know that genetic variations, once they happen in one of the genes that is responsible for one of these effects, has a very significant impact on the drug response. And here I'll show you a couple of examples. So we know that different drugs have specific prevalence to specific cytochrome enzyme that is expressed in the liver and responsible for drug clearance. For example, celecoxib and ibuprofen, so these are inflammatory drugs, and many other NSAIDs, they're actually being metabolized in the liver by the CYP2C9 enzyme that is responsible for elimination of these drugs from blood. On the other side, codeine and other opioids such as tramadol and oxycodone have to be activated by different enzymes in order to become active. And without this biological transformation, these medications are actually ineffective. So I'll go back to the slide and actually have to mention that many of these medications have FDA drug labeling information recommending genetic testing before taking these medications in order to improve efficacy of treatment and reduce the risk of side effects. So if you want to find more information about it, you can actually Google FDA and pharmacogenetics, and you will find a table which lists over 180 different medications. And some of these drugs will be there, and there will be provided explanations in the drug label explaining how these genetic variations can impact drug response. The last mark at the bottom that says CPAC, it stands for Clinical Pharmacogenetics Implementation Consortium, which is a non-for-profit group funded by NIH. And this is a group of clinical pharmacists and physicians that review different publications of associations of different variations and how they affect the drug response. And this body creates a very specific guidelines how to apply this pharmacogenetic knowledge for patient management. And I'll show you a few examples later today. So let's start with one of the most common medications that is being used for treatment of chronic pain and acute pain, Tylenol 3. So Tylenol 3 is actually acetaminophen and the codeine. And the codeine in 30 milligram range is actually a really important part of this treatment because codeine is being transferred in the liver into morphine. And morphine provides this additional pain relieving kick, if you wish to call it, to help patients to become better and tolerate pain. Unfortunately, some people are born without any functional CYP2D6 enzymes. So these people have codeine in their blood. They suffer all the side effects such as constipation. Actually, a lot of doctors say that codeine is a constipation drug, but they do not benefit from addition of codeine to acetaminophen and do not have any additional pain relief. For them, Tylenol 3 works exactly as regular Tylenol because acetaminophen is providing some pain relief, but no additional pain relief comes from utilization of morphine. Other people are having a gene duplication, and they have what's called multiple copies of CYP2D6 enzyme in their genome, and what it does, it helps to convert codeine much quicker to morphine. These people have very good pain response to codeine, but it's very short-lasting because these people metabolize codeine very effectively into actually higher doses of morphine, but eventually this drug goes out of the circulation and doesn't provide effective pain relief. So why are these issues of a concern? So first of all, the ultra-fast metabolizers are quite common. About 1% of Asians have these variations, and up to 10% of Caucasians are considered to be ultra-fast metabolizers. But 30% of North Africans, Ethiopians, and particularly Saudi Arabs are ultra-fast metabolizers. So these people are at tremendous risk of accidental drug overdose if they're taking codeine. And also they're at high risk of opioid addiction because they get very strong kick from the morphine that gets them high if they're taking even regular doses of codeine, but it provides very short duration of pain relief. And we know that FDA issued a statement that actually was dated a long time ago, as in 2007, saying that people, especially nursing mothers that are taking codeine, may cause accidental death of their own baby if they breastfeed. And the reason is that if woman takes a cough syrup that contains actually a very small amount of codeine, she can convert it very quickly into morphine that goes into the breast milk and goes into baby. And unfortunately, there were documented cases of infant death where kids were overdosed on morphine present in the breast milk. But it's also not limited to breastfeeding women. Any person that is ultra-fast metabolizer taking high doses of codeine and other opioids, such as oxycodone or tramadol, are at very high risk of accidental overdose and death. On the other side, we have to remember that people that are poor metabolizers are not able to respond to codeine and also other medications and do not have adequate pain relief. Also, people that have one copy of the enzyme, they're called intermediate metabolizers, and these are 30% of people, have reduced pain response and might require increased doses of oxycodone or codeine in order to achieve the same level of response as a normal metabolizers. So that's where the pharmacogenetics plays really important role, because we can tell you what type of metabolizer you are and what's your probability of actually having good response or reduced response to opioid medications. So here's a real-world story that unfortunately happened with one of my colleagues that worked at GeneYouIn, and her aunt was had a minor surgery in the hospital, and she was released from the hospital with Tylenol 3 for pain control. So she suffered inadequate pain control. She told her family that medication worked, but it was very short-lasting pain relief. And she by herself decided to increase the frequency of the pills that she was taking. And she didn't wake up in the morning. And the coroner's investigator identified that she actually overdosed on Tylenol 3 and passed away. And based on clinical picture and the phenotype, we could almost guarantee that she was one of these very ultra-fast metabolizers. And definitely it's a very sad story that could have been prevented if she knew that Tylenol 3 is not appropriate treatment for her, and she used some other pain killers. So, as I mentioned, Clinical Pharmacogenetics Implementation Consortium actually advises very strongly for ultra-fast metabolizers and poor metabolizers for CYP2D6 enzyme to avoid codeine, oxycodone, even hydrocodone, and tramadol, because these medications are not only not providing pain relief, but also posing very high risk of accidental overdose. People that are poor metabolizers can be actually benefiting from other opioids such as morphine or slow release formulation of fentanyl. But as I'll explain later, these are also not best options. Better options could be actually trying to use what's called COX-2 inhibitors. These are powerful NSAIDs. Other forms of NSAIDs could be also used that are not COX specific. They are better used for controlling acute pain, but also they're effective in controlling chronic pain, specifically for inflammatory pain conditions. For neuropathic pain, for some patients, pregabalin and gabapentin could be also viable options. So I'll just tell you one story that we heard while we ran an education for dentists that told we're prescribing Tylenol 3 all the time, and if patient is not responding to this treatment, I give 2 Tylenol 2 pills, and this seems to work better. So let's investigate why it's actually working better. So Tylenol 3 is a 300 milligrams of acetaminophen and 330 milligrams of codeine. Tylenol 2 at 2 doses actually provides 600 milligrams of acetaminophen, but the same dose of codeine. So essentially, if physicians prescribe you 2 Tylenol 2 pills, you're just taking 2 Tylenols extra strength, and you can forget about codeine, because it's actually the same dose and doesn't impact the clinical response. So for poor metabolizers, codeine is not effective the same way, and doesn't matter if you take 1 Tylenol 3 or 2 Tylenol 3, the codeine is not active, but actually NSAID is providing better pain relief. And it's absolutely true. There is a what's called table for analgesic efficacy that lists different medications and how effective these are in treatment of pain. And the table actually lists drugs in descending order. So Dipiron is actually not available in Canada as NSAID. It's only approved for veterinary use. But if you notice, ibuprofen at 600 milligrams or 800 milligrams is more potent than a person taking 2 Tylenol 3 medications. And this is really important to understand that NSAID sometimes could be much more powerful than even oxycodone, sustained release. So you see that oxycodone is the last cell on the line. It's less effective than ketorolac or celecoxib or other NSAIDs that are underused in chronic pain. So if you go to dentist, there is no reason to take Tylenol 3. You might be better off taking celecoxib or ibuprofen at high doses for short duration of treatment. These drugs are not posing major risk for your health. So celecoxib is very important for treatment of inflammatory pain, particularly for people with severe rheumatoid arthritis. But a lot of physicians are very reluctant to prescribe these drugs, and patients are reluctant to take them because they remember scandal related to Vioxx. So Vioxx was one of the most popular medications that is also COX-2 inhibitor, but it was taken off the market because there was a high risk of heart disease and death caused by chronic use of this medication. So Vioxx and other medications were taken off the market because of this increased risk of cardiovascular effects. However, if we look at Celiac, why some people are at high risk of heart disease, while other people can actually take these medications for treating pain. So celiac, Celebrex, is metabolized by CYP2C9 enzyme. And here's excerpt from FDA drug label that says that people that are poor metabolizers are very likely to have a high risk of heart disease. They should take half of the lowest dose in order to control the condition, or take alternative medication. So this is really important to realize that this risk of heart disease is actually related directly to your ability to clear this medication out of your blood based on this CYP2C9 metabolizer status. So what we need to learn is that some forms of osteoarthritis can be recommended, and people have to be very proactive in testing these genes in order to understand if they're a good candidate for this drug or not. So if you get a test that you're a poor metabolizer for this enzyme, you have to follow label instructions, take lowest dose of the drug, and try not to use it over a very long period of time. However, people that are normal metabolizers can take this medication safely and control their pain. Other drugs that are metabolized by the same enzyme, also sometimes used for pain management, and antiepileptics such as phenytoin and valproic acid are also metabolized by CYP2C9 enzyme. And these drugs also have labels from FDA recommended genetic testing. Furthermore, carriers of PillCheckTM gene mutations are also at high risk of neurotoxic effects. Some Southeast Asians also have a high risk of developing severe skin toxicity that is called Stevens-Johnson syndrome if they're taking phenytoin, but this risk is actually limited only to people that carry what's called HLA-D15 star 2 allele. So again, use of these medications is warranted. It poses some risk, but not for everybody, and we have to understand which patients are at increased risk and which are out of woods and can take these medications safely. So specifically for phenytoin and valproic acid, intermediate metabolizers, so these are people that carry only one mutation in CYP2C9 gene, have to reduce their dose by 25% in order to reduce the risk of toxicity. Poor metabolizers can take only half of normal dose, but at the same time, patients that are poor metabolizers could be treated with other types of antiepileptic medications such as pregabalin and gabapentin, because these drugs are not dependent at all on cytochrome CYP metabolism. So let's shift a little bit gears and think about more common things that can happen and how it can impact outcomes even from simple procedures such as colonoscopy. So people are very reluctant to go to colonoscopy because it's a very unpleasant procedure, and adverse side effects of colonoscopy is actually hearing discomfort and pain. So we had one of our early customers that did PillCheck. He didn't take any medications, but his comment was, oh, maybe this test can explain why I woke up in the middle of colonoscopy, and let me help to understand what went wrong and how my genes relate to it. So in colonoscopy, the goal of the procedure is to provide very short-term amnesia so people would not remember the unpleasantness of this procedure, but also control pain that is related to gut dysfunction. So the challenge is that you have to have a colonoscopy, but then you have to walk out of the room and become in fashion quickly. So anesthesiologist's goal is to give you a small dose of drugs to control your pain, but not overdoses, so you will be sleeping in recovery room for half a day. So the combination of two drugs used there is the fentanyl, which is a short-lasting opioid, like morphine, and benzodiazepines. So benzodiazepines are actually given to knock out you, to put you asleep and to reduce your memory of this unpleasant procedure. So with this person, when we had his test done, we know that he is what's called ultra-fast metabolizers for CYP2C19 enzyme. And he is metabolizing very quickly benzodiazepines, such as diazepam, that is sometimes used for colonoscopy. And that was the reason why he woke up in the procedure, because he didn't have an adequate dose of diazepam and couldn't sleep during the procedure. So now, once we know that this person is very fast metabolizer, for second procedure that he had to go through, because this person actually had a genetic predisposition to colon cancer, she was dosed with metabolize, which is a different benzodiazepine metabolized by different enzymes. So she was actually sleeping through the procedure, and we had numerous cases like that. That we know that people that are fast metabolizers can clear diazepam very quickly and have more memory of the procedure. On the other side, people that are poor metabolizers for CYP2C19 enzyme tend to recover very slowly from this type of anesthesia, and they become very groggy and sleepy. So that's another reason to understand what the type of metabolic response could be to these drugs in order to provide you adequate dose that is specific to you. Another case study by a very similar problem, also person with a very high predisposition to risk of colon cancer, complained that she had a very painful experience during colonoscopy. And we have been fortunate actually to analyze your entire genome for the risk of colon cancer, but also what we uncovered with this person carries a variant in opioid receptor U1 gene. So this is a gene that encodes the drug target for opioids. And the variant that she was carrying makes her more resistant to opioids. Actually, these variants are quite rare in the population, this particular one, but OPRM1 gene is big, and there are a couple more common variants that also make people to be resistant to opioid therapy. So for us, the biggest question was, what if she was homozygous for this mutation? What if she carried 2 copies of this variant? In this case, this person would not be responsive to any opioid anesthesia at all, because all opioids would not trigger the normal function of this OPRM1 protein. So the other variation that is called A118G is very common in the population, about 10% of people carrying this variant. And it's known that people that are carrying this allele are more resistant to opioid therapy. They require high doses of opioids to achieve adequate pain control. At the same time, it actually reduces the risk of addiction because they do not respond to drugs normally. But that's where the problem comes in. For example, what if you are carrying mutation OPRM1 gene, you're taking very high doses of opioids that are not working. So what other options could be available for this type of person? So as I mentioned earlier, again, non-steroidal drugs, anti-inflammatory drugs could be very effective. Specifically, the fluoxetine, what's called SLNIs, being treated for people that have central pain. Pregabalin and carbamazepine also could be used for some form of neuropathic pain. And one of the options that can be available for these people is actually cannabis. So if the person is resistant to opioid therapy, they can actually respond to cannabinoids because these are working through different pathways and not utilizing opioid receptors. However, we know that some people and physicians are very reluctant to prescribe cannabis because of stigma. But what's the difference between cannabis and opioids? So both of them plant-derived anesthetics that can be effective for some people but not others. And both of them have actually significant risk of addiction and side effects. So specifically for opioids, we know that long-term use of opioids actually causes increased sensitivity to pain. This phenomenon is called morphine-induced hyperalgesia. What it means is that with every additional dose of morphine that you take, your pain threshold decreases and you're becoming more susceptible to pain. So over a long period of treatment, opioids are not effective. So best applications for opioids are short post-procedure pain reduction, but not using them as a treatment for chronic pain over many years, because it poses huge risk of addiction, also poses reduced efficacy of this treatment, so people develop what's called tolerance to opioids. It's actually a very known mechanism. Some people that have mutations in opioid receptor genes cannot respond to morphine and fentanyl, and they may require alternative treatments. We also know that the side effect of opioid treatment is constipation, and now the drugs are being specifically designed to combat opioid-induced constipation. These are very expensive medications that creating huge burden on private drug funds. But why to utilize these medications if people should not be utilizing opioids for chronic pain management? On the other side, cannabis has a high risk of psychosis, particularly in people that have family history of schizophrenia or bipolar disorder. So it's also a very known phenomenon where kids trying marijuana in recreational purposes suffer from psychotic attacks, and this happens quite rarely, but people that have predisposition of schizophrenia and bipolar should not be using any cannabis because these are very dangerous medications for them. Cannabis also poses risk of addiction. There is negative impact of smoking that can be circumvented through use of nebulizers or other forms of taking in cannabinoids. Problem with cannabinoids is that they are very quickly metabolized. For example, why smoking is more effective than, for example, ingesting cannabinoid in form of pill, because these drugs are very quickly destroyed in the system and removed. So this way you have to actually take repeated doses quite frequently in order to provide adequate pain relief over a period of time. Nevertheless, cannabis could be a very legitimate option for people that carrying these opioid receptor mutations and are resistant to opioids and do not have any other alternative forms of treatment. So today I covered a variety of causes of chronic pain, some of which are genetic, some of those are not. Genetics can play a very important role in susceptibility to pain, but also to drug response. And proactive pharmacogenetic testing can actually help you to find the best medications that can work for you at least in some period of time in order to be able to control your pain symptoms and come in through this episode and recover from chronic pain. And lastly, just want to show you that pharmacogenetic testing is actually application of accumulated evidence for optimized treatment management. These indications are very, very well known and described in the literature. They're also present on drug labels, both on FDA drug labels and health calendar labels. Unfortunately, most of Canadians do not have adequate access to this type of pharmacogenetic testing, but we really encourage people to consider this type of form of test because it reduces risk of side effects, but also helps people to find medications that might be working for them better and to achieve better control of these symptoms. So thank you very much. I really appreciate your time, and we can come into the Q&A period.
Okay, great. Thank you for sharing that with us, Dr. Dorfman. We'll give everyone a few minutes to type in their questions if they have any in the chat box. But I was actually curious as you were going through your presentation about what this looks like on the clinical level. So if people were going to get this kind of testing done to find out if they're ultra-fast metabolizers or how they might react to certain drugs, is it as simple as a blood test that their physician would order, or what would that look like?
Not even a blood test. DNA can be obtained either from blood or non-invasive cheek swab. So people get a swab. We need to remember that genetic testing is not regular blood testing, that it takes a little bit longer time. So for example, if you expect to get regular blood test results within a couple of days, that genetic testing typically takes a couple of weeks because it's more complex and requires also post-test data processing. But again, you can find about pharmacogenetic testing on the GeneYouIn website. We offer tests that is called PillCheck. Unfortunately, in hospitals and other healthcare institutions, they do not offer this type of testing as a routine. So you can talk to your healthcare providers if they have any recommendations where to get access to this test that could be covered. We also know that this type of testing is actually qualified as a part of medical expense, so people that have insurance, this type of testing can be covered through private insurance.
Okay, great. Okay, so we just had a question come through. The question was around if we can test for an individual's reaction to cannabis and how they metabolize it.
Yes, so there are a couple of genes related to cannabis response. There was actually very recent publications that identified about 6 markers related to the risk of addiction to cannabinoids. However, we need to distinguish people that took cannabis and they can actually respond to it without developing psychotic episodes. So for these people, pharmacogenetic testing would be important to understand the risk of addiction to cannabinoids. But for other people, for example, younger people that didn't take cannabinoids, it's better to conduct broader genetic tests to understand whether they are at the risk of schizophrenia or bipolar disorder, because some people actually don't realize that they're at risk, and when they smoke marijuana, they develop this psychotic episode. So this is a different form of testing.
Okay. Well, I think that is it. Thank you all for joining us today, and thank you, Dr. Dorfman, for sharing your insights. That was very interesting. We will have the recorded version available on our site. We'll also be sending it out in an email within a couple of days, so you should be receiving that in your inbox as well. So thank you, everybody, so much for joining us today.
Thank you very much, Gillian. I really enjoyed this conversation, and I wish very well to the PainHQ, and I think you do a really admirable job in educating people about different pain strategies.
Oh, thank you. We are glad to have you join us today.
All right. Thank you. Have a good day.
Thank you. Bye, everyone.